Okay, I'm John Keel. I'm an associate professor of emergency medicine and sports medicine within the Department of Emergency Medicine at USF Morsani College of Medicine in Tampa General Hospital in Tampa. And my lecture today is the top 10 EM sports med articles for emergency medicine. So obviously this is really subjective. It's difficult. I think a different person might pick 10 different papers, right? That makes it challenging. However, I will try to stay thematic as much as I can rather than just sort of bouncing around and try to capture key areas I think that are important to EM and SM for sort of our little niche in the world. I'm not going to get wrapped up in the details of any individual paper. There's not time for that in a 20-minute lecture. I'm going to try to be mindful and not just pick EM based publications. And of course, if you guys have any suggestions or feedback, please share them and hopefully we can make this a better lecture next time if it's well received. So starting off is Dr. Chow's recommended MSK in sports medicine curriculum for emergency medicine residents. This came out a couple of years ago. There's a lot of names on here that lectured today, actually, and are well known in the EM/SM community. This is an awesome paper, and I would encourage everybody to read it. Basically, the objective was to outline and improve clinical competency in MSK medicine during residency training with a standardized curriculum. The emphasis is on knowledge, clinical exam skills, procedural skills, MSK ultrasound, consultation and referral recommendations, which is near and dear to my heart, and patient education. And then the modalities that we outlined in that paper include didactics, online modules, simulation, supervised ED experiences, and then supervised primary care and orthopedic clinical experiences. And here's a few tables I kind of cherry picked just to give you a sense of what's in it. Recommended teaching resources, right? So here's a list of books, Dr. Waterbrook's book right here at the top. And then just there's a bunch of good things in here, but I'll point out Dr. Jacobson's Fundamentals of MSK Ultrasound. So we kind of went over what books we thought were the best. Same thing with online resources. And there are, of course, many tables. I just kind of cut out little sections here, but one didactic, right? So here's some intern orientation stuff and then general didactic sessions for the whole program. There's simulation sessions, et cetera, et cetera. So really well thought out and a great foundational piece of knowledge for the specialty. And then other authors made ones for pediatrics, internal medicine, physiatry, and family medicine as well. Okay, second paper, National Athletic Trainers Association Position Statement on Emergency Action Plan. This was published last year as well. There's Dr. Dresner was one of the main authors. There's a bunch of well-known athletic trainers on here who do a lot of academic stuff. And the purpose of this paper was really just to outline what the EAP is in terms of preparation on-site emergency response planning. And of course, we know that it's designed for any type of catastrophe or injury. The goals of the EAP for this paper were to focus on optimizing patient outcomes, development, response, and implementation. And with an emphasis on the word comprehensive, I think we can all appreciate that. And essentially, the authors wanted to make sure that these emergencies can happen anywhere, anytime, and the program must be developed and executed with the entire athletic program in mind, not just the athletic trainers and physicians. And they have a table and an illustration here that outline that well. This little diagram here has the EAP in the center with the sort of core stakeholders, the team, medical, school, event, facility, and public safety. And then that sort of branches out into the secondary stakeholders, the local community, police, EMS, and the weatherman. Got to keep him in there too. Third paper, management of sideline medical emergencies. Everybody on here, presumably, more or less, is an emergency medicine physician. When these emergencies happen, everybody's going to turn to us. I know I've been there multiple times, and I'm sure most people on this meeting have. So a lot of other people feel the need to review these, and I think that's very appropriate, right? So this was a paper published from the American Academy of Orthopedic Surgeons, right? Published by a couple orthopods and primary care sports med folks. And it's a good paper. I think the importance of this to us is knowing where we land in the response patterns for orthopedic injuries versus catastrophic ones, right? Most are benign. And we're comfortable with BLS and spine boarding and equipment removal. And we're comfortable with, let's see, different slides, sorry. We're comfortable with all of these things, but not every sideline physician is, right? So this paper is really important, I think, for the specialty of sports medicine. And we just have to remember that not everybody does these things all the time. They talk about the medical bag, location of the AED, make sure it's charged, make sure everybody knows who everybody is. That's really important. And then the biggest part is, again, this comes back to the EAP, but life-threatening conditions should be promptly recognized. treated and dispositioned in a sort of prearranged fashion. There shouldn't be a lot of surprises. They have a nice table of what's in a sideline medical bag. This is going to obviously vary from institution to institution, but it's sort of a good table for the learners on this conference. And then I thought this picture was kind of funny because we all know how to do a needle decompression, but they include it in this paper because a lot of their readers do not. So good paper for emergency medicine sideline emergencies, or sorry, sports medicine sideline emergencies. All right, next paper, super important. This is an ACEP clinical policy paper published a couple of years ago, which was on ED patients presenting with mild TBI. And if you guys don't know what the ACEP clinical policies are, there's a bunch, right? There's one on syncope, there's one on head CT. It's a lot about resource utilization and saying, hey, our college supports decision making, doing less of this for this reason. In this case, this was written by a group of distinguished faculty who were updating the 2008 clinical policy on TBI. And they basically asked three important questions. One is, in the ED, is a patient presenting with a minor head injury, are there any clinical decision-making tools to help identify patients who do not require head CT? The second was, in patients presenting with minor head injury, normal neurological exam, but are on anticoagulation or antiplatelet agents, can they safely be discharged after a single head CT? And then finally, patients presenting with a mild TBI or concussion, are there any clinical decision rules or risk factors we can use to help identify patients requiring follow-up care after ED discharge, right? So three really good questions from an ED standpoint. And of course, we know what the clinical decision rules are, right? Canadian Head CT, Nexus, we use these all the time. I use them with my residents every day, I think. I've gotten to the point now where I just pull out the MD Calc and I just show the patients the Canadian Head CT rule when I'm trying to talk them out of it. New Orleans criteria is another validated one. And then on the bottom here, we have the table for all the studies that had head bleeds or were looking at head bleeds after a negative initial scan, right? And so you see those numbers are about 1 to 5%, give or take. And this is a good paper to read. This is a really important sort of landmark TBI concussion paper. All right. The next paper is by Dr. Beasley, who's a well-known pediatrician, sports med doc. And his paper came out, let's see, last year, and is a good prep for being a sideline physician, right? It forces you to think about some things other than just being a medical doctor, right? You got to think about your emergency action plan, your return to play decisions, emergency preparedness, right? Again, we're the ER docs. We're always sort of prepared conceptually at least, but not everybody has that same level of experience and gets panicky or may not be ready when something happens or know what to do. Nuanced medical procedures. This is what I thought was on the other slide, but people are not often familiar with starting, an IV, administering IV fluids, joint injections, Toradol, et cetera. All these things are second nature to us, of course. And then a good section on medical, legal, and ethical considerations for your athletes, right? So this is a good paper. And then he talks about the collaborative care approach as well. The next paper, also really important. This is the Seattle paper, right? So international recommendations for EKG interpretation in athletes, published by Dr. Sharma in the Journal of the American College of Cardiology 7-8 years ago now. And basically the premise is that screening for cardiovascular disease in athletes is difficult, right? The remodeling of their heart in response to exercise can cause EKG changes, which are not necessarily pathologic. However, we also acknowledge that sudden cardiac death is the number one cause of mortality in these same athletes. And so this makes it tricky, right? How do you interpret these EKGs? What is normal and what is abnormal? And there's not necessarily a lot of physician expertise, and then there's interpreter variability. So they tried to sort of line out what is some of the normal and abnormal findings to help reduce that high false positive rate, cut back on athlete exclusion and costs associated with a false positive EKG. So these are the Seattle criteria, very important. The first table is looking at some of the common normal EKG changes in athletes, right? Bradycardia in an 80-year-old, not the same thing as a bradycardia in an elite athlete, right? Right bundle branch block. The LVH criteria one is very interesting. So is early repole, right? So this is an EKG that would be alarming to me in the ED, but in a healthy elite athlete was interpreted as normal. All right, the last few papers I think are very interesting to me personally. So this is where it gets very subjective. Trends of Regional Anesthesia Studies in Emergency Medicine, which published in WestGem a couple of years ago. I picked this paper because I think there is an opportunity for us as regional anesthesia advocates and in many cases experts to bring some of that knowledge into sports medicine. So this paper looked at the prominence of regional anesthesia and multimodal pain control and its rise as we try to shift away from narcotics when possible. They identified that there's a paucity of data in how this has evolved, and that I think is true. It was hard for me to find a paper that was gratifying. And it highlights the articles related to regional anesthesia, so they kind of dug into what was already out there, and I'll tell you, it's not that much depth in the EM Lit. And so my question for the listeners today, though, is more about sports medicine, right? There are certainly regional anesthesia procedures that are appropriate for EMs, probably some that I don't even know about, but things like suprascapular nerve block for adhesive capsulitis or shoulder dislocation, saphenous nerve block, genicular nerve block for the knee, radial tunnel hydrodissection. I've been doing those from time to time. Not true regional anesthesia, but conceptually the same thing. So there's a lot of opportunity here, I think, for the EM physician to create scholarship and then also to maybe establish ownership and advance some of the regional anesthesia into sports medicine. Here's a table with the ED ones where, a lot of this stuff's never going to happen in an athlete, right? Why would you block an athlete's femoral nerve unless they're having surgery? But there's some that are useful, right? So like suprascapular nerve, maybe some of the rib blocks could be useful in the right patient. And then, of course, there's not a lot of the MSK related ones on here, but you get the idea. And then let's see, another paper that I picked to talk about a subject, which is MSK ultrasound in the ED. Again, there's a dearth, I would say, of papers focusing on this specific sort of subset of ultrasound among ED learners and attending faculty. This is a 5-year-old paper now, but notice this was published in MSK Radiology. I really could not find one that I liked in an ER journal. But basically what they said is, superficial structures, whether it's a skin and soft tissue or MSK, are very easy to find sonographically, and for the most part, we all can agree on that. And depending on what you include, it represents a large proportion of patients presenting to the ED. Despite that, MSK ultrasound is overshadowed by things like the echocardiogram and fast exam and rush exam and bladder and kidneys. And to be fair, those are typically more likely to be life-threatening conditions, but there's a lot of opportunity here, I think, for the EM sports med doc. They talk about pathology a little bit, but what I wanted to highlight was more about the lack of standardization of knowledge. So I've talked to Dr. Dang and Dr. Mueller about this before, right? We have our mskultrasound.net, which was sort of working on this, but there's really not a standardized MSK ultrasound curriculum for residents, and there's definitely an opportunity here, I think, to help work on that as an extension of Dr. Chow's paper on the MSK sports med curriculum. So if anybody's interested in that, there's definitely a place for us to identify some scholarship and create scholarship. Okay, my last 2 papers are on physical exam. This one is the performance of the 4-way range of motion test for radiographic injuries after blunt elbow trauma, published 9 years ago now in the Journal of Emergency Medicine, American Journal of Emergency Medicine. And I would guess that most of the people on this conference have not heard of this paper, but it's an amazing paper and it really deserves more airtime and visibility. And basically, they looked at a previous study that said limited range of motion was sensitive for radiographic injuries to the elbow following blunt trauma. And what they did is they basically said if you can fully extend and flex your elbow and fully pronate and supinate, then you don't have a fracture. And so of course they x-rayed all of these patients. They found this 4-way range of motion test to be 99% sensitive and 99% sensitive for all imaging and 100% sensitive for any surgical injuries, right? So presumably maybe there's a radial head fracture that snuck through or something, but nothing that needed an intervention. So here's the tables for that, right? So in the top here, you see the N of 92 who got the complete negative exam and 100% sensitive. You can see that sensitivity drops off, of course, if they're positive in one direction, right? That's the whole point. The point is to screen out people, not screen in, and you can reduce X-ray utilization, okay? And then there's another table talking about the performance characteristics. So this is a really great paper. I'm going to add another one before I sort of get on a pedestal here. But this second one is combining the clinical signs, improves diagnosis of scaphoid fractures. This was published by Dr. Parvizi in 1998, almost 30 years ago, in a British Hand Journal, okay? So again, I don't think most residents or faculty have heard of this paper, but also a really interesting paper, kind of the other side of the coin for the elbow one. But basically they thought there was 4 clinical signs that you could use to predict a scaphoid fracture, which was anatomical snuff box tenderness, scaphoid tubercle tenderness, pain with axial compression of the thumb and range of motion. And what they found was essentially that the first three, the snuff box, the scaphoid tubercle, and axial compression, was 100% sensitive for excluding a scaphoid fracture. So in this one, Dr. Hagraff and the emoji sort of research project that we're trying to get off the ground is looking at unnecessary mobilization of scaphoid fractures. I would look at this paper and think, here's an extension of that conversation, which is maybe we can identify patients who are confident that do not have a scaphoid fracture after either with or without an x-ray, but after a good physical exam, and don't need to be splinted. And you only have to see one patient with really bad, capsulitis from being in a thumb spica splint for too long to realize that it does cause harm down the road. And then so looking at this paper and the elbow paper, I think there's a lot of physical exam stuff that we could do, especially range of motion and tenderness following blunt trauma or minor trauma, to sort of say, hey, you don't need a radiograph for this. This is me wearing my ER hat. And thanks for coming. Your elbow exam is basically normal. You don't need any x-rays, right? So there's a lot of research here I think for the wrist, elbow, and shoulder that we could do this. Same thing with the hip. Obviously, we have the Ottawa knee and ankle rules that have already sort of accomplished that task. So there's room to do these things for other joints and maybe expand our clinical decision-making rules to other joints for orthopedics. So these are my 10 papers. Again, they were subjective. Hopefully everybody learned something or found something useful. Happy to discuss at any point. Sorry I couldn't be on the conference today. I have clinic and I just couldn't close my clinic today. But please email me with any questions, and thanks again.